As a consequence of restrictions on the use of reusable material in many countries, the Concentric Needle Electrode CNE has been shown to be a reasonable replacement for SFEMG electrodes to measure jitter. With the CNE electrode we cannot measure fiber density. New standards are necessary, which will be discussed in this video. First, a few words about single fiber in general. This is the uptake area of the single fiber electrode, 200 micron in radius. And this is the larger uptake area for the concentric needle electrode. A few words about the principle of jitter analysis. Here is a single fiber recording from a patient with myasthenia. We record from 2 muscle fibers and time lock the recording on one of the spikes, in this case the first one, and see a variability in the arrival time due to a variation in the synaptic delay in the 2 motor end plates involved. Here is a recording with normal jitter, and in the same muscle we have another position where we have motor end plates with a slightly increased jitter, and one area where we have even more increased jitter and individual impulse blockings. The jitter may be studied either with voluntary activation or, as in this case, electric stimulation. We stimulate with the needle or with the surface electrode and record the jitter between the stimulus and the recorded spike. If the jitter is less than 5 microseconds, we have stimulated the muscle fiber directly, and if the jitter is more than 5 microseconds, it is a nerve stimulation. The jitter parameter concerns time variation between 2 signals. Originally, this was obtained by measuring the time when the signal passed an amplitude level on the 2 signals. Here is the start of the measurement, and here is the end when the signal passes through the window. This technique is used in some equipment. Another method is to make peaks, mathematically peaks from the signals, and measure the variability between the peaks. Here's the triggering peak, and here's the peak on the second signal. The peak technique has an advantage in the situation where 2 action potentials are riding on each other. Here we will get an error in the measurement, but the peaks will give a more correct value. Here I will show 2 displays of jitter analysis. Here are the slow sweep speed, and this is with the amplitude level, where we see the signals here and the interval between them plotted on the y-axis, and here you have the jitter in these dots, and this is 100 discharges. This is the peak method, where we have the signals here, and the dots are now running here, and the jitter is displayed on the x-axis. We also superimpose 5 to 15 signals to check the quality of the recording. Now we will talk about the specifics of jitter analysis with concentric needle electrode. A display of some different recording electrodes to show their different recording surface, the monopolar, the concentric for motor unit analysis, the facial small concentric needle electrode for jitter analysis, and the single fiber electrode. And you see the recording surfaces have this area 0.0 to 140 and so on, and they are very much smaller in the concentric small electrode and even much smaller in the single fiber electrode. Some practical hints is that we use the concentric facial needle, usually a slightly slanted direction of the electrode through the skin. We hold the electrode like a pen. There are no specific rules for rotation of the electrode as we have had for single fiber electrode, but we optimize the signal by small movements, usually out or in. And with voluntary activation, we ask the patient for the slightest possible contraction, and we do not start to collect data until we have good signals. We try to get 100 discharges for each recording and aim for 20 recordings for each muscle. When we have electrical stimulation, we use 5 to 10 Hertz. We stimulate the nerve and insert this concentric needle electrode into the twitching part of the muscle. We use a slight stimulus intensity to get very few spikes in the recording. We must make sure that the spike in focus is supraliminally stimulated, because with understimulation we will get jitter and blocking in the stimulation point. So if the recording shows abnormal jitter, we should always increase the stimulus just a little to see whether it disappears or not. We measure the jitter between the stimulus and the spike. The amplifier settings. Here is a summary. Concentric for multi-unit analysis, 5 Hz to 10 kHz. Single fiber to get rid of some slow components is 500 Hz to 10 kHz, and the recording with the concentric electrode 1 kHz to 10 kHz is found to be the optimal. And here are some examples of recordings with the concentric needle electrode. Here is a good recording where we particularly look at the rising phase of the signals. This is the triggering, superimposable, and here you see that there is a time variability, but no change in the signal shape at all in the rising phase, no notches or inflection points. This is another recording where the signals here are parallel, but they are riding on each other. This is acceptable for the peak triggering, but not for the amplitude level analysis. This is a signal where the first component obviously is a summation of 2 or more fibers. We trigger on the second component and can measure between second and third, but not to the first. And here we trigger on the second component, and obviously here we have some disturbances. These lines are not in parallel. Here's a recording with a single fiber electrode, and you see the sharp spikes with constant shape at consecutive discharges. And here's a recording with the concentric needle electrode. This sound is a little more dull, and these signals have a slightly lower slope, longer rise time, and this is the sound of it. And here's another recording with the concentric needle electrode when we are a little closer to the 2 muscle fibers, and we get a little more sharp signals. Here I will show you a few examples of recordings. In this case we trigger on the first and we see the jitter displayed on the second one with parallel rising lines. The jitter is 15 microseconds. Here's another where we trigger on the second one and we see the jitter here 21. And here is a multispike recording. We trigger on the first and can measure the jitter between 1 and 2, 1 and 3, 1 and 4 with the different jitter values here. Here's a situation where the first spike obviously is composed of at least 2 muscle fiber action potentials. And since this inflection point here is below 50% of the maximal amplitude, we can accept this recording since this fiber has probably very little influence on the peak. When we do the voluntary activation and trigger on one of the recordings, the jitter is always seen on one of the spikes, and that is the summation of the jitter from the first triggering and the second spike. And this is particularly obvious when we have multiple spike recordings and happen to have a large jitter in the first component, then all of the others seem to have a large jitter. So here I want to show the effect of triggering. We trigger here on the first and we measure the jitter on the other 3 spikes, and here is the individual jitter values, and we summate them to something called jitter sum or J sum. When we trigger on the second component, it is another J sum, and here in the third panel we have the optimal situation, so this obviously has the smallest jitter and this should be the most correct value to report. Some instruments do this automatically and find the best trigger position. We also perform jitter analysis with concentric electrode after stimulation. Here we stimulate with a surface electrode. We can also use a monopolar for stimulation here. We start to stimulate and get the twitching part of the muscle and insert the needle into the twitching part. And then we obtain signals that may look like this. This is a very nice single fiber action potential with parallel rising phases. Here is a recording a little more complex, and obviously the first part here is a summation of at least 2 or more single fiber action potentials. So when we should measure the jitter, we do not use this one, but we can use the other 3 spikes. And we obtain the jitter between the stimulus and the individual peaks here. This is another situation, even more complex, and when we superimpose we see nice spikes here, but this one is obviously a composition of at least 2 muscle fibers. This one we do not accept, and here we have a disturbance in the peak. We do not accept this one. This is a recording that looks nice, but when we superimpose, surprise to surprise, we see that this must be a summation of a few fibers, and also here, also this component is a summation. So this recording cannot be used. Here's a recording from a patient with myasthenia with increased jitter, 64 on this one and 43 on this one. And here is another recording from a patient with myasthenia where there is a dropout of some components here during the recording. This can either be due to an insufficient stimulation strength, or it can be a neuromuscular problem. This must be tested by increasing the stimulus strength ever so little. If it is a stimulation problem, the signal will be recovered. If not, it is localized to the neuromuscular junction. Here's a superimposition of the same recording. This is a situation where this spike is not a clean single fiber recording, but you can see clearly that it must be a summation of two muscle fibers. And since this occurs above the 50% line of the spike, we do not accept this recording. We have influence, a summated influence here from the two fibers. It's not a clean recording. Here are some other recordings with after electrical stimulation, and here obviously you see an increased variability due to the diffractionation of the signal here. These are two fibers here. This is another recording with small jitter here in one component, and this one has a jitter within normal limits, but still it is not a single fiber recording, but this is a summation of at least two action potentials. Reference values for jitter obtained with concentric needle electrodes have been established in a multi-center study. Here are the mean value for a recording of 20 potential pairs, and here is the jitter, the upper normal limit for individual recording, and this is for voluntary and stimulated jitter, orbicularis oculi, frontalis, and extensor digitorum communis. One can ask about the sensitivity when we compare the diagnostic use for single fiber EMG and for concentric EMG jitter. And multiple publications recently have shown that it's very similar sensitivity between the two methods. One thing that we always note is that increased jitter and abnormally decrementing response on repetitive nerve stimulation is not equal to the diagnosis of myasthenia gravis, but a sign of disturbed neuromuscular transmission, which, for example, happens in reinnervation. A few definitions of acceptable signals. This is more important than with the single fiber recording, which is simpler and easier to get clean signals. The signals with the concentric are monotonously rising positive negative signals without inflections, an important point, without inflections, notches or shoulders. And this is best seen as parallel rising segments when we superimpose 5 to 15 discharges. For quantitative analysis, the negative peaks should be separated by more than 150 microseconds, and even more if we have an amplitude level method for jitter measurement. During voluntary activation, we must make sure that we have a relatively regular firing rate from the patient, and with electrical stimulation we should make sure that we use a supraliminal stimulation intensity. The amplifier settings for CNE Jitter analysis 1 kHz to 10 kHz, and the sweep speed should allow the detailed analysis of the signal, which means that 0.5 or 1 millisecond per division is optimal. The gain is not crucial, but usually we make sure that the signal covers about 2 divisions on the display screen. And for quality control during and after the recording, we superimpose 5 to 15 sweeps. When we assess the jitter quantitatively, we truncate high jitter values because we always have blocking of the signals when the jitter is, for example, higher than 150 microseconds, and this gives a biological disturbance to the jitter measurement. So values above that are all called 150 microseconds in summary tables and mean values. We measure jitter in two ways, either as mean consecutive differences or mean sorted differences. Many equipment can do both these recordings, and we shall use the lower of them for each recording. If possible, we should find a trigger that gives the lowest total jitter in a multi-spike recording. In stimulation jitter, we do not use the signals during the first second after the start of stimulation. There are some biological disturbances there. Reporting from multiple spike recordings is a little more complex. If we have many spikes, we report all of them if they all are normal. If the jitter is abnormal in more than one spike in such a recording, we accept the normal recordings, but only one abnormal jitter value in each multi-spike complex, the one with the lowest jitter value. In stimulation studies, we report all jitter values from each of the spike as long as they are stimulated supramaximally. At the end here, I like to make some additional comments on details for the CNE Jitter recordings. I will give examples from the studies with voluntary activation and with electric stimulation. First, the voluntary activation. The first situation that may lead to misinterpretation of impulse blocking in voluntary activation studies is discussed here. The trigger level, which I indicate here with the arrow, is the amplitude threshold for starting the sweep. All signals with amplitude exceeding this level will be seen on the screen. In this example, we are triggering on these two signals, and it's only the smaller one, the one with lower amplitude, that has a double peak. The other one is a single one, and one can see the difference. This one is different from this one, and this one is different from the others. Here is another example, the same situation, trigger level here, and now it happens to be the white one, the higher amplitude signal, that is connected to another fiber. The yellow one is single. This may look like an impulse blocking. During activity, the muscle fiber conduction velocity is increased, and after a rest less than 1 second, the velocity goes down to a basal level. This is seen when we activate the muscle with bursts of stimuli and insert a pause here and a pause here. After the pause, the latency is longer. And if this pause comes in irregular intervals, it will add to the jitter. This irregularity is seen during voluntary activation, which adds a little to the jitter. And also if we have impulse blocking, that is disturbing both during voluntary activation and at electric stimulation. This is the most typical problem with electric stimulation. Here, two muscle fibers are activated initially, and they belong to the same motor unit. They occur all the time here. In order to make this stimulation supraliminal, the stimulus strength is increased a little, and now an additional spike is seen since a new axon is stimulated. And with another small increase in stimulus strength, a third axon is stimulated, giving its responses with a longer latency. This axon is stimulated subliminally because you see that the some of the impulses are missing. So we cannot measure the jitter on this one since it's not stimulated properly. And had we increased the stimulus to get this fully stimulated, then another fiber may have been seen, now in turn subliminally stimulated. This is a recording from a healthy muscle. It's not a myasthenia. Sometimes with intramuscular stimulation, we see latency jumps in the response from this position to a shorter position. This is explained by so-called axon reflex. This is a schematic explanation of axon reflex. A weak stimulation, the recorded fiber is activated antidromically this way with a long latency, an axon reflex. With stronger stimulation, the electric field is increasing and will reach this part of the axon, closer to the muscle fiber, and therefore a shorter latency. The latency difference corresponds to the time on the axon reflex. Here's an example of a recording with latency jumps. Here's a given stimulation intensity. Here's high, and then we reduce the stimulus intensity. This line is drawn to the right, and we get a longer latency. And then again, we increase the stimulus intensity, and the latency is again shorter. When the reflex arc is long, the jumps are easily seen, but the reflex may be very short, and now the dual latencies are difficult to detect. And here is the distribution of latencies of the response. And when we superimpose, we may here and there see a clear dual distribution, but it's not so clear overall. And this could easily have been misjudged as an increased jitter. Then we have a few questions that are frequently asked. A short video like this does not cover all the aspects of CNE jitter, and some of the questions can be: can we measure fiber density with CNE? I said already from the beginning that is not possible, because that has a completely different uptake area compared to the single fiber electrode for which the fiber density is defined. So here we rather rely on multi-unit potential parameters. Which muscles are optimal for the myasthenia diagnosis? Well, we should go for the symptomatic muscles. Often that is facial muscles, but if there are limb muscles, we should go for those. The typical is, however, that we record from orbicularis oculi and the frontalis muscles. And the rule is that if the first investigated muscle is normal, then we go to the other of the two. Internally, they have about the same diagnostic value. And if two muscles, particularly if they are symptomatic, have a normal jitter, then it's very unlikely that it's myasthenia, and to add a third muscle usually is not fruitful. then it's better to ask the patient to come back after 3 months. Another important question is that about previous Botox injections. Remote effects of Botox can cause jitter in many muscles, and I should say that an unexpected finding of increased jitter should always lead to the question, did you have a Botox injection? The effect remains for a long time. It's unclear how long it is, but at least 3 or 6 months, even more in certain publications.